medications are one tool that we can utilize, but physicians, doctors, those of us that prescribe these meds, we're not going to solve obesity by itself. We know that it's multifactorial. We know that we have to look at that built environment. So maybe architects come into play. Maybe we have to look at faith-based environments. Maybe we have to look at schools and governments and policies. I mean, there's so many different facets that we have to address. For us to assume that medication will solve this is really short-sighted.
Today we are talking about obesity. Obesity in terms of genetics, in terms of treatment, in terms of the future and what it could mean to you. And for that, we are turning to a specialist to help navigate these complicated waters. She is an associate professor of medicine and pediatrics at Harvard Medical School, as well as obesity medicine and science as the doctor at Massachusetts General Hospital. With that, we welcome our friend, Dr. Fatima Cody Stanford. Thanks for being here, Dr. Stanford.
Oh, I'm excited to be here with you, Chuck.
Obesity is such a hot topic. When is it not, really? But it just seems like, especially of late, you can't open up your phone, you can't turn on the TV or the radio, the newspaper without hearing about it. You talk about it for a living. Have you noticed an uptick in the conversation?
Absolutely, Chuck. I agree with you. I think our whole world has been infiltrated with this discussion about obesity. And I really think within this year, just 2023, we've seen this become a part of the normal conversation that people have at their dinner tables. We see it on TikTok. We see it on Instagram. I can tell you now patients bring in information they've read on social media or in the lay press about obesity. And so this has become a major focus. And I think there's a lot of reasons why we've seen this major shift, how it's become really the key point of conversation outside of major other news and as it relates to politics or whatever it might be. I would say that this is the number one health topic being discussed here in the US and around the world.
And because there's so much coverage, there's also so much confusion. So let's try to clear that up. Okay. Number one, when it comes to obesity, there seems to be two camps. There seems to be this camp where you have no control over it and it's just kind of your destiny. If it's genetics, that's the way that it's going to be. But then you have this other camp where it says, well, you have way more control over obesity than you think. What has your research and your experience shown you to be true here?
Yeah, actually, I don't see it really quite that way, Chuck. I see it as a continuums, of looking at, different influences on different persons. Some people have more of a genetic influence than others. Some people have other issues that may have led them to having obesity. Maybe there are medications that cause weight gain or whatever it might be. So I think the conversation that I see, particularly as it relates to my research and the research of many of my colleagues in the space, is that we know that obesity is this multifactorial chronic disease where we have different perturbations, meaning different things that are leading a person to have the disease, but that it is not the person's fault. I think that's a thing that if you were to talk to my colleagues, myself, look at our research, is that we don't want to put the blame on the individual because, for example, we do have lean individuals that are able to have very poor habits as it relates to lifestyle modification, et cetera, but nobody sees that because unfortunately obesity is a disease that you wear. And so when you carry excess weight, people make assumptions about what you are or are not doing. If you happen to be someone that carries excess adipose is a fancy word for fat, people assume you're lazy, undisciplined, careless, passive. And then if you happen to be a lean person, people assume, oh, you must work out all the time. Maybe you eat vegetables all day. But these assumptions lead us to these really dueling issues that we see in terms of looking at obesity as a disease in which a variety of factors play a role in how it's regulated within one's body.
All right, let's talk a little bit more about those factors. It is multifactorial. And, as somebody who's lost close to 300 pounds themselves, the first time somebody told me that it wasn't my fault that I was overweight was well after I had lost all the weight. And I kind of looked at them, Dr. Stanford, like they had two heads, like I didn't have any clue what it was they were saying or why in the world they would have even said it. Because as somebody who struggled with their weight, I did not know really why this was happening to me. I did know that my diet had a lot of room for improvement. And so I thought that was my fault. And certainly, the food that I was putting into my body, one could argue you have total control over, but that brings food addiction into the conversation as well. But from where you sit, What are some of the more common factors that determine whether or not a person develops obesity?
Yeah, well, I think there's some big groups. So let's look at some of the big categories, and then we can kind of hone in on some minor categories. We know there are over 100 different causes of obesity, so I can't go through all of them, or that would be the full show, and we don't want to spend the full time there. But let's look at, for example, genetics is one component, and so we know that obesity is highly heritable. We've seen this, and this research really has been around for 70 plus years. When we look at twin studies, and we see that if you have people that are what we call monozygotic twins, which means identical twins. You separate one in China, put one in Zimbabwe, somehow, bring them together 40 years later, their body habitus still reflects a very similar nature, despite the fact that they grew up in very different environments. So I always like to talk about weight being as heritable as height. And so when we're born to tall parents, we assume that the children will be tall, right? Or if we're born to shorter parents, we assume that the children will be short. And there are rare circumstances when that's not the case, but on average, that's truly the case. And so genetics can play a role. So that's one, kind of umbrella. Developmental. So what was mom and dad's weight status, even in utero, that can influence things. The food and beverage behavior and environment, Chuck, you've talked about specifically that food and beverage behavior and environment. We've spent a lot of time focusing in that area. And that is an area of consideration, but it is not the cause of obesity for everyone. And it can be highly contributory for certain people. We know that psychological issues and distresses can lead to weight and weight regulation. And the environment, the built environment, structural racism, all of these things can play a role. So it's a lot of different things that kind of branches, and under each of those categories, we have many things that you could explore. Weight stigma and bias. So a person that carries excess weight, unfortunately, receives a lot of bias. I mentioned that, not too long ago. That can lead to excess weight. So there's a variety of reasons why people may struggle. These big categories of genetics, development, environment, behavior, these are some of the big, huge categories under which some of these underlying issues do fall.
It's such a complicated issue, isn't it? I mean, there's so many layers to this. Let's stick, though, with the genetics, though, because what we know is that when it comes to genes and certain diseases, there's switches, essentially, that you can flip on and off. You were citing, twin studies there. Well, it can be that one twin develops heart disease, another twin does not. One twin develops Alzheimer's, another twin does not. Genes really, based off of your diet, your lifestyle, all those other factors we were talking about, they can be suppressed here. So really, if you were to ballpark it and put a percentage on how big of a role genes play in terms of the amount of weight a person carries, could you give us a ballpark percentage there?
Yeah. So, if you look at the studies, somewhere between 40 to 70%, which means that it can be highly contributory. 70% is pretty large. If you were taking a test, however, in school, a 70 would not be a great grade. I can tell you I would not have been able to complete all the degrees that I've done with the 70 being my baseline evaluation, but 70% is rather high. So if there's a 70% chance of rain, most of us would think, I need to probably take my umbrella today, right? So not that it was 100% chance that it'll rain, but there's a high likelihood. And so that's what we see. And particularly with me treating families, I treat patients that go from twinkle to wrinkle, meaning they range in age from 2 to 90 years old. In many situations, I am caring for full families where I'm taking care of the children, the parents, the grandparents, and in 2 situations, even the great-grandparents. So there's high heritability of that disease. And so when they bring in their 2, 3, 4-year-old, I'm not at all surprised because I'm dealing with the milieu of them being born to parents that had obesity. Now, they could have been leaner children, but if you have 2 parents that have this disease, unfortunately, that really does increase your risk.
All right, it took me a second. Twinkle to wrinkle. That's clever. I like that. So here's my question, though.
Yes.
Even though we're talking about genetics, obviously you inherit that DNA. As we often like to say, you also inherit the recipes from your parents as well. But I don't think it's a stretch to say that, and I've seen this, and it's in my personal life now as well. You have people in your family who eat one way. You have people in your family who eat a completely other way. And they have a whole different, it seems like a whole different frame. One is struggling with their weight. The other one is not. So how much of the blame then could be, and I don't even really like the word blame, to be honest with you, Dr. Stanford, but
Yeah.
how much of that comes from, just like the family lifestyle altogether? So if somebody's eating, that king size Whopper combo for dinner, but then somebody else is opting for, say, like healthier whole grain pasta, marinara, something, clean like that, they're going to have a completely different body composition. So when you're working with families, how much are you seeing there?
Yeah, not always. I mean, when we're seeing patients in my center, we have a multidisciplinary approach. So we have someone like myself that's on the medical side. We have our dietitians, we have our psychologists. And so, you have those three components that are being honed in with our PhD level psychologists, our MDs, and our dietitians who are registered dietitians. We look at that full picture. And for many patients, particularly that are coming into me, there sometimes are needs for modifications in the diet realm, but for many of them, it's really outside of that realm by the time they've gotten there. They've already made these significant improvements in diet modification, exercise modifications, and their bodies are signaling down the pathway of the brain, which tells them to store more adipose or more fat. So many of my patients actually have diets that are much more superior to their leaner counterparts. They have to work at it, and they can write the book on what the best dietary strategies are. And this is where I want to get away from that blame, even in the language that we're saying. So we're assuming that someone that's leaner is eating healthier, and we're assuming that someone that's heavier is not eating as healthy, or they're eating much larger volumes. But there's differences in how our bodies decide to also store. So I might eat something and my body may decide, you know what, I'm only going to just store 10% of that. And another person eats the exact same thing and they store 90% of it. It's not that we did anything any differently, but my body doesn't externally express that additional adipose. And so you assume that I must do something better, or the assumption is made, when indeed that may not be true. And that's where I really want to make sure the conversation is changed, because that's what I see many times, particularly when people make it to me in specialty care. They've tried and failed and tried and failed and tried and failed. And usually when you hone in, it's not the diet quality that's a piece of the puzzle. Their body stores more adipose. And this is why we've seen really the significant rise in anti-obesity medications, et cetera, where we are able to shift the signaling of the brain to the more favorable pathway, which tells us to eat less and store less.
Yeah, but we're going to talk about the drugs here in just a second, but I am curious, like a lot of my story, thinking back of it in hindsight, the seeds for obesity were planted at a very young age. And I'm wondering if the body almost trains itself to hold on to more fat depending on the types of foods that get introduced at an early age. My diet was very poor at a very young age. And I'm wondering, like, had I just been eating whole fruits, vegetables, things like that growing up, as opposed to going through the drive-through or those sugary breakfast cereals in the morning, would my body have said, well, I don't need to hold on to fat quite the way that I have been?
Yeah, there's definitely some likelihood that definitely influenced, how your body saw weight, right? Like that early introduction to highly palatable, which means they taste good, energy dense foods is not what we want, right? We want to introduce, but even in utero, if you were exposed to that could have had a significant influence on you. So it's hard to say because each person is different. I can tell you, like, particularly when I'm taking care of these different individuals of different generations, you can imagine that the grandparents then are teaching the parents, which then teach the kids. And even though they've really modified what they do in terms of their eating, their bodies still are predisposed to store a lot more. So it just, I think we have to recognize that there's not a one size fits all approach, and there's not even a one size fits all answers to saying, like, well, was that something that could have been modified? Yes, indeed. We want clean diets as much as possible. And so that could have influenced your likelihood of storing significantly more adipose that you were able to take off as you really invested in your lifestyle modifications. But I don't want that language to get into such that then the child that's now 5 years old, it's a matter of you assuming that they were introduced to that exact same less desirable fare of foods, which led them to, having their obesity. Does that make sense?
It does. And it just brings me right back to what it is we've been talking about. Like, this is some complicated stuff. There is not a one size fits all answer for this stuff, even though I think by and large, that's what we really want, is that one solution, that one answer.
We do. I mean, wouldn't it be nice? I mean, my job would be easy if I could just just say, this is the answer to the question. I mean, you take this magic pill, you do this magic exercise, you eat this magic food, right? These, that's what we've been taught. You just do this thing. And if you do these things, you should be the exact size you want to be. But unfortunately, it's just not that easy. I mean, it's so complicated and there's so many different varieties of reasons why someone may struggle. What I do is I spend time trying to figure out what those reasons are. What are the 5, 10, 12, 15 reasons that person struggles with weights, and which ones can I directly address? There's some that are outside of my control, right? I know that I don't have the bandwidth or the tools yet to address certain key things. Like if you live in a built environment that's crime prone, I can't change that for you. I can't change the stress associated with being in that environment, which then leads to greater storage of adipose. But there may be other things that I can have an impact on. And so my goal is to work on those things I can address, to help address with the patient, and then find the best solution for the person in front of me at a given time.
Before we talk about drugs, I can only talk about me here as an example, even though this interview really is not about me. I just want to use myself as an example in case somebody else has the same thing. So I grew up, not a lot of money. Utilities were being turned off quite a bit. Kind of a rough school, not exactly the greatest environment, not what a lot of people expect when they hear my backstory. So you have that as one factor here, but let's say that with that same identical life experience, you have someone, again, myself, let's say I was eating that cleaner, more skewed, I eat a plant-based diet. So eating the plant-based diet versus me who ate that almost exclusively fast food diet, 10,000 calories a day, got up to 420 pounds at my heaviest. If somebody had that same life experience and was eating that cleaner diet, what are the odds they would still get up to those 420 pounds, though? That's kind of my big question.
I don't think we have that answer, Chuck. I wish we had that answer, but I think that obviously there will probably a lower likelihood of that person getting to that level if that diet was clean. But we have to think about how those stressful environments, you said lights were being turned off, that food insecurity, we know, is a huge component of obesity. All of these things play a role in the body assuming it needs to store more. So when it feels as though there is pressure on the system, the brain does what it did when we were hunter-gatherers. The brain says, oh my gosh, there is lack. There is not enough. Let's store more fat. Let's protect this individual from a famine that doesn't typically come because you know what? You get that 10,000 calorie diet that you can then look to. But that's not what the body knows. The body knows, oh, I need to store. There's a lot of uncertainty in this environment. So that uncertainty can be a huge contributor. But when you add that additional layer of that food environment not being ideal, that can be a perfect storm for an individual. Now, like you said, if you had a clean diet, potentially there would have been a lesser degree. Maybe you wouldn't have gotten to 420, but maybe you still got to 320. Does that make sense? So, but it's hard to say exactly what that is because we'd have to go back and relive your life.
I'm glad where I'm at now. I have no interest in going backwards. I'm looking ahead.
Yeah.
All right, let's switch gears here and talk about these weight loss drugs. I mean, again, you can't turn on the TV or thumb through any kind of blog without seeing Wegovy, Ozempic, Montgomery, like all of these things here, these GLP-1 drugs, as they are known. You kind of touched on it a little bit earlier, but how exactly do these things work?
Right. So first of all, I want to note that there are several medications that are approved by the FDA. This newer class of medications are what we call GLP-1 receptor agonists. GLP-1 stands for glucagon-like peptide 1 receptor agonism. This class of medications has been around since 2005, but was initially approved only for the treatment of type 2 diabetes. And they work in a few key ways on the body. First, we need to recognize that there's two key pathways in the brain that regulate weight. There's one pathway of the brain, what we call the anorexigenic. And when you hear anorexia, you hear less food intake. So that's the POMC, or the pro-opiomelanocortin pathway. That pathway tells us to eat less and store less. And then there's another pathway called the AGRP pathway, which is the GUDI-related peptide pathway. That's the orexigenic. Orexigenic is the opposite of anorexigenic pathway. That pathway tells us to eat more and store more. So these medications work by upregulating, so stimulating that pathway, that's the anorexigenic pathway, and downregulates the AGRP pathway. So it works, that's the key mechanism in how it works. It also slows movement through the GI tract. So the GI tract is what we call the gastrointestinal tract, everything from what we eat all the way to what we dispose of in the toilet when we have a number 2 situation. But it moves slowly through the GI tract, so you improve satiety. So let's say, Chuck, you go and eat breakfast. Let's say you eat at 8 a.m. And if things are moving slowly, maybe at 1 o'clock p.m. in the afternoon, you are not even hungry for lunch because you know what? Things are still moving so slowly through your GI tract that you feel like, hey, I'm full. You know, people are asking you about lunch and you're looking at them like, what are you talking about? I'm still full from breakfast, which was at 8 o'clock. So that's the second way. The third way it works is it improves your insulin secretion. So insulin is a hormone that's secreted or let out by your pancreas. And so it stimulates your body's own ability to do that. And those are the 3 primary ways. There's also some data which suggests that it helps us to brown our fat tissue. And when we brown our fat tissue, we improve our resting energy expenditure, meaning just sitting around talking like this, we might burn more because we have ability to burn more at rest. So those are the key ways and how that class of medications works. Now, there's several other medications that work in different parts of the brain. A lot of our stimulants are anorexiant drugs, which have been around since 1959. They inhibit a hormone, or like something called norepinephrine within the brain, a particular hormone. And then we also have other agents that may stimulate something like GABA, which is gamma aminobutyric acid. We have different mechanisms of action, but what you can kind of hear kind of universally is that many of these mechanisms happen within the brain, particularly within the hypothalamus.
I mean, there's a whole lot of science there. I'm not a doctor, so thank you for breaking that all down for us. What is the average success of these weight loss drugs right now? What do we know?
So it depends on which one we're talking about. I can take you through all of them.
By all means, let's go.
So let's do it. So the EQUIP, CONQUER, and SEQUEL trials looked at phentermine and topiramate, which has been approved by the FDA in combination. On average, when we're looking at total body weight loss, now let's say total body weight loss, let's say you're 100 pounds, think about a percentage of that. So we were looking at somewhere between 8 to about 9.5% total body weight loss with that combination. There's another combination of medicines called bupropion and naltrexone, usually between 2 and about 6% total body weight loss. The first generation GLP-1 is called liraglutide under the trade names of Victoza and Saxenda. Those medications between 6 and 7% total body weight loss. So those are kind of that first generation. Those are kind of the initial drugs. Now, when we get into our second generation GLP-1s, semaglutide, which is also known by the trade name of Ozempic for the treatment of type 2 diabetes, and Wegovy for the treatment of obesity, we see on average in adults about 15% total body weight loss. So you can hear that that's a much larger number than when we talked about some of the more traditional meds. Now, when you get into another agent called tirzepatide, which is a GLP-1, but it has another type of medicine in it or component, it's called a GIP. So you have a GLP-1 with a GIP. GIP stands for glucose insulinotropic polypeptide. It's a dual agonist in a single molecule. On average with that, we see a much higher percentage of total body weight loss. We're looking at about 22% total body weight loss with that agent, with that dual agonism. So you can hear these numbers going across the range. But what's important to note is that different people are responders or non-responders. You may have someone that you put on, let's say, semaglutide, which is that Ozempic or Wegovy, and they may lose 30% of their body weight. And you can put someone else on it and they lose only 2%. We don't have a way to predict who's going to be a responder to any of the classes of medications. And so there's often some trial and error involved to figure out what works for the right individual.
The first one you mentioned, bupropion, isn't that an antidepressant? What is,
Yeah, so bupropion is a dopamine reuptake inhibitor and is combined with naltrexone. Naltrexone is an opioid receptor antagonist. Together, they're approved by the FDA for the treatment of obesity. So bupropion, which you did say was an antidepressant, is also used to treat smoking addiction or tobacco addiction, and is also used in combination to treat obesity. So it has a lot of versatility.
Interesting. So how would you determine like which drug is right for which patient? Is it really trial and error? Is there a way that based off of specific responses and past history of a patient that a doctor might be able to say, "Oh, well, I think you'd be a good candidate for this one."
Well, no, I look at more like what is the full issues with the patient. So, for example, if we're looking at our GLP-1 receptor agonist and a patient has evidence of a higher blood sugar or evidence of prediabetes, but also they also have obesity. So that might be a good agent to consider because we're going to address two things at one time. We're going to address their issues with their blood sugar while also addressing their issues with weight. Let's say a patient does have depression, for example. Let's go back to that bupropion naltrexone. And maybe they also have a history of opioid use disorder. That bupropion naltrexone would be a phenomenal combination to consider in that patient because we're using a drug that's going to prevent them from having those temptations as it relates to opioids while also treating depression, but also treating obesity. For someone who has issues with migraine headaches, that phentermine topiramate component might be great because topiramate helps to prevent migraine headaches. And so do you see what I'm saying? So you're listening to like what is all going on with the patient and then making a judgment, but then also recognizing that we still don't know how well their individual response will be until we try it. So a lot of times my patients will say, well, hey doc, how much am I going to lose? And I'm like, well, your body is the answer key. I won't know until we try it in you. Yes, I can tell you what the data shows. I can pull up slides from the New England Journal, but that doesn't tell me about you, the person in front of me, and you're asking about yourself. I have to see. Your body will tell me the answer.
Yeah, it sounds a lot like something that I know you're a big proponent of, and that's personalized treatment. Again, going back to not one size fits all. It's impossible. There's 8 billion people in this world, and we're all a little bit different, aren't we?
We're all a little different. So I tell them, look, I don't know. And then sometimes we're surprised. Like, for example, you put someone on a medicine like those ones that had lower percentage weight loss, and then they come back and they've lost 20%. And they're like, wow, this is amazing. And I'm like, who knew? I mean, that's great. That means this is a drug that we're going to keep you on. But I wouldn't have known that answer because it's not average. It's like, really a top 1%er in terms of their response.
Just housekeeping question here, curiosity here. When you're talking about 20% weight loss, is that 20% excess weight or total body weight?
Total body weight. So when we look at those numbers that I gave were all about total body weight. So for example, if we're talking about 22% total body weight loss in a 100-pound individual, that's 22 pounds, right? If we're, making the math pretty easy there. I don't know many people that weigh 100 pounds unless they're, adolescents and growing. I don't think I have any patients that weigh that, but just to make the math easy, right? So it's total body weight loss that we're talking about.
And it seems like, with obesity, there's a lot of comorbidities that just they come right along with it. You mentioned that a lot of these drugs have other treatments as well. So I'm wondering what the data shows in terms of, helping in that regard as well, whether it's something like diabetes, high blood pressure, things like that.
Well, almost all of the medications are going to address obesity and obesity-related disease. And it's what I enjoy about the work that I do as an obesity medicine physician is I have the pleasure of deleting diagnoses from people's charts. It gives me great pleasure to take away their history, hypertension. I could say history of hypertension because they had it in the past, they don't have it now, or history of high cholesterol. Most of the medications, when they're targeting this total adipose, total body weight, which also affects adipose and fat, we are going to see an improvement across basically most of the obesity-related diseases. There's specific data that's recently come out, particularly looking at the GLP-1 agonists, which is very compelling. Some of it's older data, some of it's newer data, showing a reduction in fatal and non-fatal stroke, fatal and non-fatal heart attacks, death from any cause, hospital admission for heart failure, all of these types of things, which are really quite significant. And so on average, we see these really great outcomes in what we call meta-analyses, Chuck, which are pooled studies where we don't just take Fatima's study or Dr. Stanford's study. We take my study and the other 20,000 studies that were published on that topic and pool that together to determine what is the real effect, not just the effect in Boston, the effect also in Italy, the effect also in Zimbabwe, the effect in Australia, and pool those together. And those are the highest strength of evidence. And so with pooled data, these meta-analyses, we see really significant improvement in obesity-related disease across the spectrum.
I think from a patient perspective, and perhaps also from the practitioner perspective here, with such data available there, I think it'd be easy for somebody to say, well, look, these are the solution. These weight loss drugs are the solution. Do you view them as the entire solution or just part of the solution for the patient?
No, I think it's part of the solution. I think that when we're talking about obesity, because we've talked about it being multifactorial, multi-sector, there's so many different things that have to happen to really look at the long-term effects for patients, right? Medications are one tool that we can utilize, but physicians, doctors, those of us that prescribe these meds, we're not going to solve obesity by itself. We know that it's multifactorial. We know that we have to look at that built environment. So maybe architects come into play. Maybe we have to look at faith-based environments. We have to look at schools and governments and policies. There's so many different facets that we have to address. For us to assume that medication will solve this is really short-sighted.
Have any of these studies also looked at these medications working in conjunction with, other lifestyle modification things, stress reduction techniques? Obviously, we've talked a lot about diet. So when you put the more holistic side of things together with the modern medicine side of things, is there some extra synergy there?
Yeah, I will. I did that with a little bit of hesitancy because some of the newer medicines, we see less of an impact of lifestyle modifications on outcomes. So kind of the stronger the medicine, the less likely you're going to see a small improvement, with the lifestyle added, but much more minimal. Some of those other medications that we talked about, the phentermine, bupropion, naltrexone, et cetera, we get a much larger benefit from what we call intensive behavioral therapy, which looks at dietary modifications, physical activity, things of this sort. So I think as the medications become more potent, we just see a little bit lesser response. I still highly encourage it, right? Because we get so many benefits from eating healthy and exercising beyond just the weight perspective, right? So I highly emphasize this within my patients, even if it's a minimal increase over some of the more potent medications. But notice it is an increase, just a smaller amount of really response.
But real talk, and this is just my 2 cents coming at you, I think it's the patient, again, is always going to be looking for that one thing. And it's going to be really hard for them to say or to think, especially initially, that the pill isn't going to solve everything. I was put on blood pressure medication, Dr. Stanford, when I was 14. And what that did was for more than a decade after that, I still was like, I got these pills, I'm good to go to the drive-through. And I did. And my blood pressure was still way out of control, but I convinced myself that as long as I had that pill, I was good to go. And that's a trap that we get into.
Well, yeah. I don't think that my patients have that issue. My patients, whether they like it or not, we're going to go over every single lab in detail, every single visit. And we're going to compare that to the labs they had 3 years ago and compare that to the labs they had 5 years ago. And we're going to see that improvement. We're also going to look at those parameters like their blood pressure and their pulse and see. My goal is to show them that this is not just about weight, this is about health improvement. And so when we look back, at a patient that came into me at 65 that's now 75, we see a significant shift in positive gains on the side of their metabolic health. And so I think that if you're not having that deep dive with your doctor, then you might just think, hey, this is going to magically solve everything. But these medicines alone aren't capable of doing that.
All right, let's talk about what happens when somebody's been on them for a year. I've seen reports out there that most people stay on them for a year, maybe 2, and then they come off. What do we know in terms of what happens to a person when they no longer are taking these medications?
Yeah, the data is very clear. If we're no longer acting on those pathways of the brain, what do we expect? We expect them to regain. And that's exactly what the studies have shown, exactly what we see in real life. Much like if you were going back, Chuck, to your example about high blood pressure, if you're taking the medications, right? So some people are on 1 or 2 or 3 or 4 blood pressure medicines. We can control it while you're on the medicine. And if we pull it back, a lot of times we see those numbers come back, similarly with high cholesterol. And the same happens with anti-obesity medications. When you are taking them and if they are effective for you, meaning you're a responder, as soon as we pull that back, we do see weight regain because we're no longer acting on the brain to influence how the body is regulating weight when you're off the medications.
Would you say that then puts it kind of, it almost makes it imperative that those lifestyle lifestyle modifications are also made as soon as the person goes on these
Well,
medications, knowing where this may end.
Yeah, I mean, and I'm in a very different situation. So by the time patients get into me, like I said, most of them have made significant lifestyle changes, and they have over the last 15, 20, 30 years. I have one patient that can show me every exercise that he's done since 1996 until now. So, I mean, I have like a different cohort. By the time they make it to obesity medicine, they usually have tried a lot. Now, if you're just the general population, maybe you've never tried anything before, but that's not the patients that I see. By the time they get into me, they've tried and failed over many, many years often, unfortunately. And so I just have a different demographic of those people. And usually my patients are highly committed to their lifestyle. There's some that I still have to encourage, particularly as it relates to physical activity. But from a dietary perspective, they tend to be more ideal than not on average.
And correct me if I'm wrong with these numbers, but I got this from a pretty widely publicized study came out last year, found that within 1 year, most patients had regained about 2/3 of the weight that they had lost. And then also from the same study, within 2 years, all of those cardiometabolic improvements that they had also experienced had been wiped out. Is that about right?
Chuck, you're right on it. I mean, that's part of why when I say to a patient, look, if we're going to try this, if it works, we don't stop this, right? If you are a responder, if we're seeing improvement in cardiometabolic parameters, if we're seeing an improvement in weight, all of these things, we're going to continue on this indefinitely. I explain that before we get started on a medication. And I say, if you are a responder, because I know that different people may not respond. And it's not their fault that they didn't respond. I say that the treatment failed them, not that they failed the treatment. And so you're right. You've hit the nail on his head in terms of what we see, particularly in terms of weight regain and unfortunately a reemergence of cardiometabolic risk factors.
And here's another interesting conversation, right? If somebody does stay on this long term, what do we know in terms of what the potential long-term risks are for the use of this medication for years on end? What do we know there?
Well, it's exactly what I said already. So we know that with pooled data for the last 18 years, we see a reduction in fatal and non-fatal stroke, fatal and non-fatal heart attack, all-cause mortality, which means death from any reason, hospital admissions for heart failures, et cetera. That's what we know from the data for the last 18 years. So that's what we know.
So 18 years. All right. Because I've had doctors come on and they're like, look, I wouldn't trust a drug if it hasn't been tested for 10, some even say 20 years, because we just don't know what the risk is at that point. What would your response be to one of your colleagues who's like, yeah, these things are just too new. I don't feel comfortable prescribing them?
I would say to my colleagues, I would do a deeper level of investigation to really see what we do know about the data. As someone who's published close to 200 studies, I know the data very, very well, and we have a lot of robust data. Certain populations, for example, the pediatric population, I would say we have less data just because we haven't used these drugs as long in that younger age group. But within adults, we have a lot of robust data. When the first medication came out in 2005, I mean, we're almost at 20 years and we have this data to evaluate, and individuals that had a higher disease burden than individuals that were using these medications in now. So that would be my response. If they feel uncomfortable prescribing these medications, I would say don't prescribe them. Leave that to people that do feel comfortable, and we'll spend the time with patients helping them understand the risk-benefit ratio.
Yeah, and here's the thing, like, it's just, again, just like obesity, this is so hard. And I think, like, from the patient, when they reach the doctor's office is more often than not just desperate and doesn't really care. Just give me something that's going to help me right this very second. And that makes me think back to, when I was first prescribed antidepressants, when I was in the 6th grade as well. That was a transformative year, let me tell you. But I remember my mom remarking to me, and I don't know if she saw a study on this or what the case may be, but she's like, over time, these can really impact your liver. They can impact your kidneys. I didn't care. I was just miserable. And I think that, even an informed patient in that moment would make the decision a lot of times to go ahead and get those drugs. But, what do we know, though, in terms of, is there any data out there as far as like, can it make your organs wonky, anything like that? We heard the upside, but what else is there?
No, I mean, I think you're asking, like, what are some side effects of the medications?
Right. Right.
We don't have,
Right.
I think of it in terms of that. So, it depends on which class of medicines we're talking about. You've asked me about the GLP-1 agonists. We know that nausea is a very common side effect. It's usually transient in nature, but up to 45% of individuals can experience nausea on these medications. Obviously, with nausea can potentially be vomiting, constipation. We talked about slowing of movement through the GI tract. That is definitely something that's a very common side effect for these medications. People can have persistent constipation. You don't want to use these patients that have a history of pancreatitis, or you want to be very cautious. But some people, very rarely, can develop pancreatitis. If someone develops pancreatitis, then you would stop these medications because the risk of it causing another pancreatitis issue, which can land you in the hospital, is high. These medications are completely contraindicated, meaning we cannot use them in patients that have a history of medullary thyroid cancer or family history, or patients that have something called multiple endocrine neoplasia type 2. We cannot use these medications. So those groups of people are completely excluded. And so these are important to consider. I would also advise extreme caution in women of reproductive potential. And the reason why I say that is because we do recommend, particularly for the GLP-1s, that you come off the medicines approximately 2 months prior to conception. And so if you are planning to conceive, or even if you're not planning but think that's a possibility, you want to be very cautious in terms of utilizing birth control and things of that sort to prevent pregnancy, just because there's risk associated with that.
All right, let's go to the slowing of the emptying, so to speak, the slowing of the digestive tract. I've heard it even referred to as gastric paralysis, which sounds like that just sounds so sinister.
Yeah.
But there are studies out there that show people who suffer from constipation are at a higher risk for developing other diseases, and it can be as simply put, as has been explained to me on another show, that basically your waste is sitting in your system longer and it reabsorbs into the body, and that's how bad stuff happens. So if you have this slower digestive tract, is it possible because of that a person could be facing a higher risk of other types of diseases that haven't really been thought about yet in terms of these drugs specifically?
Yeah, no, I wouldn't say that's definitely the case, right? Some people do have things, all of us have really different pace of our GI system. We know those people that are going to have a daily bowel movement, some that are going to have 3 daily bowel movements, and that's their norm. I would just say that, I become, concerned when my patients are like, oh, I have a bowel movement every week. And you're like, my gosh, that's a little too slow. So often in those situations, I am using things to help relieve that degree of constipation if their system is really significantly slower. But there isn't anything that I can potentially think of specifically with this slowing of movement through the GI tract. I think we would have picked that up from data from like 05, 06, 07, et cetera, having a predisposition to disease process because of that.
A couple more here for you. Really enjoying this conversation. Man, I could talk to you forever. And I've heard from a friend who says she has friends who go to this, essentially what they call a spa, and they go and they get these injections. And she's like, they have no business needing anything to do with weight loss, whether it's surgery, whether it's drugs, whether it's a diet. They're already well within the normal BMI range. What happens to a person when they go and they get these injections and they really just don't need them?
I'm not a proponent of people using these medications that don't desire them. I think that this can cause, weight cycling. So as they come off of it, they may have a higher weight regain from wherever their baseline was. Also, it's not regulated. What are they really getting? Are they getting medications that have been well studied? Are they getting compounded medications that we have no data on? There's a lot of key issues associated with these medi spas using these medications and giving them to patients. I don't encourage it, and actually am emphatically against this. I think that you need to be evaluated by a physician or other healthcare practitioner that's knowledgeable about these medications and using them in the right population. And so those are my thoughts, Chuck.
All right. And in terms of just diet here, housekeeping, because I know a lot of people who are listening and watching this right now, they're all about the food. So oftentimes it comes back to carbs when it comes to weight loss. And I've seen in a number of articles on weight loss medications, always they bring carbs into the conversation as well. Where do you weigh in on carbs and whether or not they should or should not be part of somebody's diet with these medications, without them, whatever? I will go to my grave arguing that the carbs in a whole sweet potato are far different than the ones in a Hostess donut.
They're very different. I don't pay attention as much to the carb count. I don't ever put my patients on carb restriction. I believe that patients should have a full, well-rounded diet where they have lean protein, whole grains, fruits and vegetables. More complex carbohydrates, obviously, we would emphasize for individuals. But I don't believe in really an all or nothing approach. Keeping my patients in ketosis or any of these things are not things that I recommend for patients. I've actually written case reports on actually quite to the contrary of that. So I'm not a part of this conversation of needing to restrict carbohydrates. I do support complex carbohydrate consumption, and even in some occasions, more simple carbohydrates, but much more rare occasions.
All right. And final thing, I was just doing a weight loss panel with Dr. Garth Davis, among others, bariatric surgeon in Houston. Okay. And he was talking about a new procedure that he expects to really explode within the next few years. What is next in terms of what you're seeing for the battle against obesity, Dr. Stanford?
Well, I think that what hopefully we've learned from everything that we've seen is that, like, first of all, number one, you said it's not a one-size-fits-all equation. If we're looking at bariatric surgery, many of my patients have undergone bariatric surgery. There is a honeymoon period after bariatric surgery. I call that the first 6 to 12 months where everything's going quite well. We've changed the signaling in the brain, but unfortunately, the brain remembers, and those signaling that really improved in a very desirable way start to wane. And so you might need to add medication. You might need to adjust lifestyle, etc. And so I really think the key thing is looking at the individual, going back to that personalization, recognizing that one person may only need lifestyle modification to address their obesity, and one person may need lifestyle modification plus surgery plus medication plus a device to address their obesity. It doesn't mean one is better than the other. It just means that they require different levels of therapy to treat their disease. And so I would say that we're going to see more multidisciplinary care. I think we're going to see more cohesion between, let's say, bariatric surgeons, obesity medicine physicians, dietitians, like exercise physiologists. I think we'll see more of that. And then, of course, we'll see the emergence of more and more medications. For example, at the American Diabetes Association meeting, we have medications now showing almost 25% total weight loss, what we call triple agonists, which is a combination of GLP-1s, GIPs, and glucagon receptor agonism. And we'll continue to see more and more of that come down the pike as people recognize obesity for the complex chronic disease that it is.
All right. We'll leave it right there. But I've really enjoyed our conversation today. This has been a real treat for me. Dr. Fatima Cody Stanford, thank you so much for your time.
Thank you so much for having me, Chuck. It's been a delight.
Thanks for watching. If you got value out of this video, please like it, subscribe, and hit the notification button to see our next